Well, good afternoon to those of you who have joined, and welcome to those who will be coming on as I'm speaking. But I want to say how excited I am to have you join the March issue, if you will, of our monthly lecture series. And we're really in for an excellent lecture on some new and cutting edge research and clinical practices. And our speaker is Joanna Streck from the Harvard Medical School. And I'm going to turn things over to Stacy Sigmund to do an introduction of Joanna. Stacy?
Thanks, Steve. Welcome to everyone with us today. And it's really my pleasure to introduce Dr. Joanna Streck. Joanna is a terrific colleague and has been my collaborator for over a decade. And she's now an assistant professor in psychiatry and medicine at Harvard Medical School. And also the associate director of addiction science research and programs at Mass General. In addition, Joanna is a core faculty member in the MGH Tobacco Research and Treatment Center and the MGH Center for Addiction Medicine. And last but not least, she is also a licensed clinical psychologist at the MGH Substance Use Disorder Bridge Clinic. Overall, Joanna's research seeks to identify effective tobacco cessation and other risk reduction interventions for a wide range of vulnerable populations who smoke, including those that we're very familiar with here at UVM, those with comorbid substance use disorders. And so, Joanna, just a big thank you to you in advance for being willing to share your work with us today.
Let me share my screen. Thank you very much for that introduction, Stacy. Let me just put this in presenter view. All right. Thank you so much for having me here today. I'm going to discuss low threshold substance use disorder bridge clinics and integration of evidence-based behavioral health services. I have no conflicts of interest to declare, and the views presented today do not necessarily represent the views of the University of Vermont. So in terms of an agenda, first I will describe the low threshold bridge clinic model of addiction treatment and the supporting evidence there. And then I'll share a proposed bridge clinic behavioral health model, including discussing two notable gaps in care and how we're addressing those gaps with innovations at Mass General. And then I've left time at the end for Q&A and discussion. Okay. Despite robust evidence for the effectiveness of medication treatment for substance use disorder, SUD is vastly undertreated in the US. As an example, in 2023, only 18% of patients with opioid use disorder who needed treatment received any form of medication treatment for their OUD. And as a result, we've seen in recent years rising rates of substance use related mortality. And relatedly, we've seen increases in recent years in substance related emergency room visits and hospitalizations, including for infectious complications related to drug use. Now, most people in need of addiction treatment don't receive it due to issues accessing treatment, namely systemic barriers like rigid requirements for addiction treatment entry and continuation. And indeed, the majority of existing addiction treatment models out there are considered high barrier models of care. So this is a portion of a table from SAMHSA, which defines high barrier models of addiction care in terms of their general requirements and approach to treatment. And you can see in this leftmost column here that there are various service engagement requirements, including predetermined visit frequency requirements in order to obtain treatment. Often we see in these models that addiction treatment is discontinued due to evidence of ongoing substance use. Generally, treatment goals are imposed on clients, and often abstinence is imposed as the primary goal that clients need to meet all the time. In the second column here, we see the various requirements for patients to receive a medication treatment for addiction, So in many clinics, patients are required to come to 2 or more visits in clinic before a medicine can be dispensed. There's often limits on medication formulation and dosages. And then finally, in the last column here, we see issues related to availability, where often this treatment is only available in specialty addiction programs, and it's often not integrated with treatment for highly prevalent comorbidities like psychiatric disorders or infectious disease concerns. And the way treatment works is that patients have to call to schedule an intake appointment to establish treatment, but there's often a delay of at least a few days before they can initiate or have that intake appointment, I should say. And then finally, these clinics generally only have traditional business hours of operation, and services are only available in person. So the take-home message here is just that the requirements of high barrier addiction treatment really limit treatment access. In addition, there's been documented patient-perceived stigma and discrimination in these models, and we see well-documented racial disparities in addiction treatment access and retention in treatment. As a result of these barriers, there have been widely established calls, including recently from SAMHSA, to establish low barrier, also called low threshold, substance use disorder bridge clinics in general medical settings to remove barriers to treatment engagement and improve access to addiction care. And bridge clinics get their name in that they're designed to bridge gaps in care, to provide high-touch support and stabilization to those not already connected to addiction treatment before eventual referral to longer-term, more longitudinal addiction treatment. In recent years, bridge clinics have really proliferated and been established across the US. As of 2023, there were bridge clinics in over 10 large medical centers across the country, and I know a few have developed and been established since 2023. There's also been a growing number of state-funded and statewide programs, such as the California Bridge Program, which integrates the bridge clinic model into California-based emergency room settings throughout their state. One of the first bridge clinics established was at Mass General, and they were established in 2016. And later in the presentation today, I'll share with you some data from our MGH Bridge Clinic. But first, I'll share with you the overall model of addiction care in a bridge clinic. So in terms of the population that the bridge clinic serves, this is generally a group of people with active, untreated, unstable substance use disorder. They're not ready or stable enough for high threshold addiction treatment models. And in addition to not being connected to other addiction care, they're also generally not connected to other needed medical or psychiatric care. Psychiatrically, this is a population who's often in crisis. We see high rates of comorbid psychiatric illness, particularly high rates of severe PTSD and trauma. And for our population, the trauma is not always historical. It's not always based on a traumatic event in one's past, but we see a lot of patients with ongoing chronic trauma. We see patients involved in trafficking and other issues of exploitation. And there's an interesting literature showing that for most people with addiction, trauma often predates their substance use disorder and can be seen more as an etiological or predisposing factor for the later development of a substance use disorder. Our population also has serious mental illness, such as bipolar disorder, psychosis, among others. And this is a group that really faces adverse consequences from their social determinants of health. So we often see patients who are unhoused, have issues with financial security and transportation, and even trouble accessing basic needs like food. Many of our patients have been kicked out of other addiction treatment programs or barred from returning or denied entry, in part because they often don't meet the requirements that I presented on the prior slide, but they're also often kicked out for different behavioral issues like yelling at staff or various behaviors that's not tolerated by higher threshold treatment models. So taken together, bridge clinics serve a very high risk population. In terms of their substance use, it's a group at very high likelihood for overdose and related mortality. It's also a very psychiatrically complex population. Bridge clinics are strongly rooted in a harm reduction model that focuses on treatment engagement. And they provide care to all people without any service engagement conditions or preconditions. The hallmark component of what bridge clinics offer is on-demand, same-day access to addiction treatment, including medication treatment for addiction, Patients can walk in at any time without an appointment, and these models are often available to patients either 24/7 and or during unconventional hours of operation, like on the weekends or at night. And they offer virtual visits in addition to in-clinic visits, including virtual visits during which medication treatment for addiction is prescribed virtually. We also offer other bridge short-term care, like bridge primary care, bridge psychiatry, among other social services. And we offer specific harm reduction services like safe injection supply kits or fentanyl test kits. And the idea is that once the patient, once their substance use disorder stabilizes, they would be transitioned to longer term care, and the Bridge Clinic team has a smaller team that helps link people to longer term, more longitudinal addiction treatment. The primary staffing group or role group across all Bridge clinics are the addiction medicine physicians and their staff, who are obviously the people who can prescribe the medication treatment for addiction. Many Bridge clinics have one or all of these ideal role groups, like psychiatrists, a behavioral health team to provide therapy services, a resource specialist, a peer recovery coach, and that's someone with lived experience in addiction who provides a non-clinical support coaching. And the ethos is really meant to be one of multidisciplinary team-based care, a more horizontal versus vertical model of team-based care where all staff voices are equally valued and respected. As an example, the entire team, ranging from the peer coaches to the physicians, often attend and contribute to the weekly rounds and case discussions. So now I'll present that same SAMHSA table, but now I've populated the top row with the low barrier model of care. I won't spend too much time on this slide, as much of it I've already discussed in prior slides, but the take-home message here is just that the low barrier models of care have no service engagement conditions or preconditions to obtain addiction treatment. We've removed in the second column all of the medication requirements, and availability is much higher in these clinics. So low barrier care is more widely available. It's integrated with other services such as psychiatry and often infectious disease. And importantly, it's available to patients same day without an appointment. There are extended hours of operation, and we offer telehealth in addition to in-person services. So what do we know about the data on the efficacy or the effects of the Bridge Clinic model? This data is very much in its nascency, although we do see a growing body of literature developing, which does support the utility of Bridge clinics in increasing initial access to addiction treatment, including access to medication treatment for addiction, and patients report decreased stigma when they're treated in this model. To my knowledge, there's only been one RCT testing the Bridge model, and the other studies are a handful of studies that largely use cross-sectional data, like data from chart reviews or qualitative data. So I'll share with you briefly the one RCT. This was called the Bridge Randomized Clinical Trial. It was conducted by Markovitz and colleagues at Vanderbilt. And they enrolled 335 adult inpatients with opioid use disorder who were seen in their inpatient hospital by an addiction consult team. And patients were randomly assigned to either be referred to a co-located Bridge clinic after their hospital stay for opioid treatment, or referred to a community health provider to receive MOUD. The primary outcome was changes in index admission length of stay between the groups, and they did not find any changes in index admission length of stay between randomized groups. There was very low rates of follow-up in this study, so only 26% of their sample completed follow-up assessments. There were promising outcomes on the secondary outcomes. So patients referred to the Bridge Clinic were more likely to be linked to a healthcare provider who provided MOUD, more likely to have more MOUD refills, suggesting they were retained longer in treatment, and less likely to experience an overdose compared to those who were referred to the community health provider for treatment. 2 points that I want to make about how this Bridge Clinic that was studied at Vanderbilt might be unique from the other Bridge Clinic models we have is that the authors reported that their Bridge Clinic did not have the capacity to accept all of their patients, so that's unique. And also the authors reported that they excluded patients with severe psychiatric disorders from participating in the trial. One other study I'll share with you was conducted by our larger addiction director at Mass General, Sarah Wakeman, who published a paper in 2022 using chart review data from our Mass General Bridge Clinic. And she found that 70% of Bridge Clinic episodes of care resulted in initial engagement with care, which was defined as completing the first 2 Bridge Clinic visits. So that's depicted in her schema here, where we see that 19 and 11 of 2730 episodes of care, which is that 70% engaged, completing the first 2 Bridge Clinic visits. And that's often where the medication treatment for addiction is prescribed. Though we see many less patients are retained at 30 days, and even less patients stick around beyond 30 days at 60 days to be transferred to longer term addiction care. So the early data that's coming out looking at the Bridge model is definitely promising, but we need much more research, namely prospectively designed longitudinal studies to investigate the short and longer term care trajectories following initial engagement with a Bridge Clinic. And we know next to nothing about the impact of Bridge Clinic-based behavioral health services on addiction treatment outcomes, nor how behavioral health services may facilitate addiction treatment engagement, including engagement with life-saving medicine for addiction treatment. So now I'll talk to you more about our proposed Bridge Clinic behavioral health service model. The behavioral health model has not been formally developed in low-threshold Bridge Clinics. And part of that is because not all Bridge Clinics have funding to include behavioral health services, but also historically, the population that the Bridge Clinic serves is not one that people generally think to offer behavioral health services to. So this is, again, a group with active untreated addiction, which is generally not a population that people assume would be interested in therapy or behavioral treatment. But we know that that actually isn't the case, and not what we're finding at all in the MGH Bridge Clinic. This is actually a population who could hugely benefit from behavioral health services, but these services really need to be adapted to this population and delivered thoughtfully. So we've been working on developing this behavioral health service model at MGH, and I'll share that model with you in a moment. I want to briefly just talk about what we know about evidence-based behavioral treatment more broadly for addiction and the pertinent history. So I know this audience is familiar with this, and many of you in the audience were the pioneers of this bolded statement, but that evidence-based behavioral treatment for addiction includes contingency management and/or MI and cognitive behavioral therapy-based approaches. And we also see growing evidence supporting the third wave behavioral treatments for addiction. Now, historically, addiction treatment clinics did not offer evidence-based behavioral health services, but they did mandate the counseling services that they had in order for a patient to receive a medication treatment. So, for example, in many methadone clinics, they historically didn't offer evidence-based services, but they would mandate that patients engage in their counseling services in order to get their methadone. And more broadly, this model resulted in counselors who had really high caseloads and inadequate training, and patients were ultimately dissatisfied with this treatment model. So my recommendation would be that we would not extend this model to high threshold treatment models, and definitely not low threshold models of addiction treatment. There is an extensive literature on cognitive behavioral therapy for addiction and for other psychiatric disorders, and this literature has long discussed the importance of process factors like the therapeutic relationship, and found that the therapeutic relationship is highly predictive of therapeutic outcome in CBT. Yet patient-centeredness in CBT delivery and how to deliver CBT in a patient-centered manner really has not been addressed. And this is really a critical factor that has to be addressed when thinking about how to deliver evidence-based behavioral health services in a low-threshold addiction treatment setting. So the model that I'm proposing today, I'm just calling tentatively low-threshold patient-centered cognitive and behavioral therapy. And the content of this behavioral health therapy model would include the evidence-based content that I just showed on the prior slide. You'll see I added in community reinforcement approach. I'll say more later in the presentation about contingency management in this setting, but just to briefly note that we train our fellows and our therapists on community reinforcement approach, as it's something that uses naturalistic reinforcers in one's environment and doesn't require clinic resources or monetary or vouchers to deliver the principles of it. So the evidence-based content listed here is similar to content that we would see in a high threshold addiction treatment model, but where we really adapt our model for the low threshold setting is in how we deliver the evidence-based content. and that we're much more flexible in how we deliver the content. So we don't deliver our evidence-based skills in a manualized, rigid way. Rather, we meet patients where they're at. We're quite flexible on the length and duration of treatment. As an example of that, I'm often referred patients after they're released from a prison or jail setting where it's very hard for them to sit in a room with me for more than even 5 minutes. So rather than force that or flood them with a longer session duration, I would, of course, meet them where they're at in that situation and have a shorter session. We spend additional time on rapport, trust, safety, and validation. Many of these terms are in line with trauma-informed care and the tenets of trauma-informed care, and the acknowledgement of patients' history of discrimination in the medical model. We've also been working to use the work of Carl Rogers in a Rogerian approach to how we deliver our evidence-based CBT and behavioral treatments. So the tone that we take is one of unconditional positive regard and non-judgmental acceptance of the patient in terms of how we deliver our evidence-based skills. And then this might go without saying, but there's very close collaboration with other providers and role groups so we can properly provide wraparound addiction care to our patients. So I'll give one brief example of how we might approach behavioral treatment in a low threshold bridge clinic and how that might differ from conventional CBT in a higher threshold model. So the situation in this example is that a patient is 25 minutes late to their therapy session. In a high threshold model of addiction treatment or traditional CBT, often a rule is that you don't permit the session to begin if the patient is a certain amount late to a session. That's generally something you discuss in your intake with a patient, and lateness is considered a therapy interfering behavior. In some treatment models, if the tardiness or lateness or no showing continued, they might even be ejected from treatment. Whereas in a low threshold model, we might say something like, I'm so glad you could make it in today. And we would hold the therapy session, even if a natural consequence may be that the therapy session is abridged because you have a patient in the next slot. And for some people in the low threshold model, given we really emphasize treatment engagement, therapy session attendance might even be a therapy target of yours or an exposure target. The last piece I'll say about a tenet of our proposed model is that the Bridge Clinic Behavioral Health team provides critical consultation to other role groups in the Bridge Clinic. So we often help our other role groups like the addiction medicine physicians navigate challenging interactions with patients. One situation that we see a lot is patients who are engaging in risky behavior, and it's a situation that we can't really fix or change. And we have to sort of tolerate our own anxiety about that situation or our own emotions. So for example, we often see patients who are using fentanyl and overdosing, and maybe our provider has recommended a evidence-based medication treatment for opioid use disorder, but the patient may not be using it or using it consistently. And so we can't, force the patient to take these medicines. They have autonomy, but these can be really challenging cases to watch when you care about your patients. The final piece that we work on a lot is this complex dialectic between providing low threshold care, offering care on demand to everyone and anyone, regardless of where they're at or what they're experiencing, and how you balance that with having boundaries in the care that you deliver. So one extreme example is that we don't tolerate staff abuse or our front desk staff being, yelled at. So this is something that comes up a lot in terms of how you deliver low threshold care. And how you protect your staff and also protect your patients by having them feel more contained with more structured boundary care. The final piece that I want to talk about related to the Bridge Clinic behavioral health model before I move on is just sharing 3 representative quotes that I think align really well with the ethos of the model that we're trying to build and channel. The first is one from 2 scholars and clinicians who said, we argue that CBT, cognitive behavioral therapy, can be practiced as a highly empathic, person-centered form of therapy. And this was the article that went on to argue for using the work of Carl Rogers in unconditional positive regard and non-judgmental acceptance of a patient in terms of the vehicle for which you deliver evidence-based skills. And I think this is really well suited for a low threshold addiction treatment setting. The second is a quote that I read in grad school. That's actually from an American businessman who wrote a book about how to be effective and productive in a professional space. but it really stuck with me. It was, if I were to summarize in one sentence, the single most important principle I've learned in the field of interpersonal relations, it would be this: seek first to understand, then to be understood. And I've actually used this quote. I lead a didactic and train providers on how to navigate challenging patient interactions in the addiction and pain treatment space. And I always recommend that this is a quote the provider follow as a first step in a challenging patient interaction. So often we see patients in our inpatient hospital who are hospitalized for addiction complications. And a challenging interaction is often that we have a patient angry or yelling, demanding a higher dose of a pain medicine or an opioid, or a higher dose or a dose of a benzodiazepine for their anxiety. And in many cases, the provider might not think it's indicated to increase that dose. They could walk into that hospital room and immediately seek to be understood and say, you know what, this behavior is inappropriate and I'm not increasing your dose. I'm not giving you that medicine. Or they could first walk in and before they set their boundary and say their piece, they could first seek to understand the patient. They could walk into that room and say, you know, I understand you're in a ton of pain right now. You're extremely anxious. You've been in the hospital for a long time. I'm so sorry. I really want to help you. And then set that boundary and say, you know, but I'm worried about this, so I can't increase this medicine, et cetera, et cetera. And that is likely to land better, lead to less dysregulation, and be better heard by the patient. And that leads me to my last quote, which is how we can show patients that we understand them and that we're listening. And that's by validating. So validation means that you understand where the other person is coming from, even if you disagree with what they say or do. And you can validate someone's behavior, their thoughts, their emotions, and you can also choose to intentionally not validate a behavior if you don't want to reinforce it or have it increase in frequency. And instead, you can validate their emotion or their experience. Okay, so now turning our attention to two notable gaps in behavioral treatment for addiction. And these are gaps more broadly, not just in the low threshold setting. And then I'll share with you, after I share the gaps, two innovations that we're working on at the MGH Bridge Clinic to address these gaps. So the first is that we really don't have access to effective stimulant use disorder treatment. So I know you all are very familiar with the fact that contingency management is a first-line behavioral treatment for substance use disorder, and it's actually the only evidence-based treatment for stimulant use disorder because there's no effective pharmacotherapy for stimulant use disorder. This was well stated by the recent guidelines from the American Society on Addiction Medicine for treating stimulant use disorder. They say CM has demonstrated the best effectiveness in the treatment of stimulant use disorder compared to any other intervention studied. It represents the current standard of care. And they go on to recommend that CM can be combined with other evidence-based treatments that I've already talked about today. And yet, despite this clear and well-documented efficacy of CM, it's not available. And so right now, I can't, in the clinic I work in, just refer someone to get CM for their stimulant use disorder. And that is in part due to the fact that there's no public payer coverage of CM. CMS has cited fraud concerns, although they've agreed to investigate coverage of CM for addiction. But often clinics don't have internal resources to fund CM either. So I'll talk with you in a moment about a way that we're working to overcome this at Mass General. A second notable gap is that there's really limited provision of effective tobacco cessation treatment in addiction treatment settings. So we see in the data, in the literature on high threshold addiction treatment settings, that there's a very high prevalence of tobacco smoking and mortality in populations with addiction. But we see that providers in addiction treatment settings really offer limited provision of evidence-based tobacco treatment, despite patients' interest in tobacco treatment. So first, I'll talk with you about our CM implementation effort. So Sarah Wakeman, again, who's our larger addiction services director at Mass General, who couldn't be here today, she recently obtained internal funding from our larger Mass General Brigham Hospital healthcare system to implement and integrate contingency management for addiction treatment into our bridge clinics. And she is planning to integrate them into not just Mass General, but our larger healthcare system, so also into our Brigham and Women's Hospital bridge clinics. So we've been meeting as a team to develop this protocol before we launch it. I'll share with you today the draft of the protocol that we've been thinking of, but I thought this was a great opportunity and audience during the discussion and Q&A to take anyone's feedback on how we might edit this protocol to be most effective. So we're planning to incentivize patients for completing the Bridge Clinic intake assessment and subsequent early treatment engagement. So we're planning to incentivize the first 5 Bridge Clinic visits, which typically occur over 6 weeks. Recently in January, SAMHSA increased the amount we can pay patients in SAMHSA-funded clinics for contingency management. So fortunately, we can now offer $750 per patient per year, which gives us a pretty good magnitude incentive, allowing us to pay roughly $100 per each of the 5 visits. We're planning to recruit patients who have a substance use disorder and are receiving care in one of our Bridge clinics. Our data show that most of our patients have either an opioid or an alcohol use disorder at the Mass General Bridge Clinic. And this makes sense because that's where we have the effective pharmacotherapies. And most of those patients have a co-occurring stimulant use disorder. So by having this eligibility criteria, we would be capturing and treating those with stimulant use disorder. But we would use a CM attendance protocol. So we'd be incentivizing attendance, and we would incentivize attending the intake visit. And then in line with our patient-centered model of care at the Bridge Clinic, at the end of the intake visit, we would meet with the patient and present them with a menu of treatment engagement opportunities and see which target behavior they'd like to choose to get incentives for attending. I only list a few here, but there are many other individual and group offerings and resources in our Bridge Clinic and in our sister Bridge Clinic at Brigham and Women's. And finally, we'd pay through gift cards. Mass General doesn't allow us to compensate in cash, but we would use gift cards and ideally make them reinforcing to the patient by asking them where they want their gift card to and make it, again, patient-centered. So this is our draft protocol, but I'd love to hear the group's feedback, and I'll take that back to our larger team as well. Okay, so turning our attention to the next implementation effort. So the majority of the data to date, all of the data, I should say, on tobacco smoking prevalence and provision of tobacco treatment in patients with addiction has been conducted in high threshold addiction treatment settings. There's no data on the prevalence of tobacco smoking or the provision of tobacco treatment in low threshold addiction treatment settings like the Bridge Clinic. And if I haven't already made this clear today, this sample is really unique in the Bridge Clinic. They're at very high risk for overdose. They're not stable. They have a high rate of psychiatric comorbidity. So one could argue this is the most vulnerable group of patients, and one that historically many have argued are not appropriate for tobacco treatment. So to begin to answer this question in a low threshold setting, we recently conducted an electronic health record chart review and looked at Bridge Clinic encounters at Mass General from 2019 to 2023. We were able to pull data on almost 1,600 patients, and we investigated cigarette smoking prevalence at the initial Bridge Clinic visit, provision of tobacco treatment by a Bridge Clinic provider within 60 days of the initial Bridge Clinic visit, and then whether the patient had a documented tobacco quit status at 12 months after the initial Bridge Clinic visit. So presented here is the data on tobacco prevalence among our Bridge Clinic patients. The N reduced a little bit because this was the amount who had a documented smoking status. But on the x-axis, I have each substance use disorder diagnosis after the all category. And the bar shading represents the presence of co-occurring stimulant use disorder, with black representing stimulant use disorder, white shading representing absence of stimulant use disorder. And the y-axis is the percent currently smoking. The reason I showed the substance use disorders diagnoses like this is for what I mentioned earlier, where polysubstance use is the norm in this sample, and the majority of people have stimulant use disorder with another disorder. So this allowed me to show the polysubstance combinations. But if we start in this all category and look at the gray total bar, this is saying that among all of our patients seen at the Bridge Clinic who have a substance use disorder, 66% were currently smoking at the intake visit. That prevalence jumps to 80% when we look at patients with any stimulant use disorder. Moving over to opioid use disorder, we see that 83% of patients with opioid and stimulant use disorder smoke cigarettes. The prevalence is slightly lower looking at the total or those without stimulant use disorder. Our lowest smoking prevalence was seen among patients with any alcohol use disorder, where among patients with alcohol use disorder, smoking prevalence is 41%. That jumped to 61% when we add in co-occurring stimulant use disorder. And by far our highest smoking prevalence was seen among those with opioid use disorder and alcohol use disorder and stimulant use disorder, where we had an 84% smoking prevalence rate. And then our other subcategory is those with cannabis use disorder, sedative use disorder, and non-opioid alcohol use disorders. And we see a similar story there, where overall this group has a 56% smoking prevalence rate, and that jumps to 70 when you add in co-occurring stimulant use disorder. And maybe not surprisingly, we saw a dose-dependent relationship where we saw increasing smoking prevalence with the increasing number of substance use disorder diagnoses. In the next slide here, I'm now showing the inferential statistics on the prevalence data. So this is a general linear model predicting current tobacco smoking among patients seen at a Bridge clinic. On the x-axis, we have the adjusted rate ratio, which can be understood like an odds ratio. And on the y-axis, we have each factor in the model. And you can see alcohol use is the reference group, I should also say. But you can see compared to alcohol use disorder, those with opioid use disorder or opioid and alcohol use disorder together have higher odds of current cigarette smoking at baseline. And also those with stimulant use disorder compared to no stimulant use disorder also have a higher odds of current smoking at baseline among patients seen in a Bridge clinic. None of the demographic factors like race or age or gender were predictive of current smoking in this model. Now looking at the provision of tobacco treatment by Bridge clinic providers, looking within 60 days of that first Bridge clinic visit, we saw that 17% of patients were prescribed nicotine replacement therapy for the purposes of quitting smoking. Only 1% were prescribed varenicline, and in total, we saw 18% of our sample were prescribed either NRT or varenicline to quit smoking. We weren't able to pull the data on bupropion, which was our other FDA-approved smoking cessation pharmacotherapy, because we couldn't determine its indication, whether it was for depression or smoking cessation, in a sample with a very high depression rates. We had low rates of follow-up smoking status documentation. So only 20% of our sample had a documented follow-up smoking status 12 months after the Bridge clinic intake. Of the people who had a smoking status documented, 9% were documented as having been quit or being non-smokers at 12 months. And the quit rate did not differ among those who did or didn't receive nicotine replacement therapy. We didn't have a sufficient sample size to look at that across varenicline use. Preliminary conclusions from this chart review study. Among patients seen at a Bridge clinic with substance use disorder, 66% were currently smoking tobacco. The highest prevalence of cigarette smoking was seen among those with any stimulant use disorder. The diagnostic combination with the highest smoking prevalence was stimulants with opioid use and alcohol use disorder concurrently, probably driven by the number of SUD diagnoses. Following the initial Bridge clinic visit, 18% of patients were prescribed a medicine for smoking cessation. The first thing I'll say about this is that this is really promising. Again, this is a very high-risk population that many would argue are not interested in smoking cessation or not appropriate for it. And we didn't find that. We actually found that this is a population who does seem to be engaging with tobacco treatment, which is really promising. The 18% rate of tobacco treatment provision is a bit lower than the most recent national estimate I could find from the NHIS in 2022, which showed that 36% of the general adult population received either NRT or varenicline, but still promising overall. So our conclusion here is that Bridge clinic providers should increase their longitudinal assessment and documentation of tobacco use disorder, and also increase their provision of FDA-approved tobacco treatment pharmacotherapy. And one idea I have for doing this would be to train our non-physician staff on the basics of tobacco treatment, to share this responsibility and increase the number of staff trained to deliver tobacco treatment, knowing and acknowledging that our addiction medicine team already is quite overburdened and has a lot of clinical priorities in short visits that are billable. So in terms of our future directions with this tobacco work, we have ongoing and planned research to increase tobacco treatment provision at the MGH Bridge Clinic and also in other addiction treatment settings at MGH. We have a grant that got a fundable score, which is proposing to train addiction peer recovery coaches to deliver behavioral tobacco treatment and compare that to standard non-peer tobacco treatment specialists delivered tobacco cessation treatment. And we provide dual NRT in both groups. So hopefully that gets awarded. And then we have an ongoing study which is testing electronic cigarettes for combustible cigarette reduction among patients who smoke receiving opioid treatment at Mass General. And we're recruiting in both of these studies at the Bridge Clinic and in our other low threshold addiction treatment settings. And I've presented the e-cigarette data at a different VCBH conference, and the data does show evidence, early evidence of cigarette reduction upon use of e-cigarettes in this sample. So now zooming out and just talking about, briefly talking about the overall conclusions and future directions from this larger presentation and body of work. Low threshold Sudbridge clinics are expanding across the country, and the data that's coming out is promising and shows that they increase initial access to life-saving addiction treatment and reduce stigma associated with addiction treatment. But we need much more prospectively designed longitudinal studies that look at patient outcomes, including addiction treatment outcomes, following engagement with a bridge clinic. We also need to bridge gaps in behavioral health care delivery in low and high threshold addiction treatment settings. One way to do that is to continue to advocate for public payer coverage of CM to support its implementation. We see rising rates of death due to stimulant-involved overdose deaths. And as I mentioned, and as you all know and are the experts in, contingency management is the only evidence-based treatment for this. We also need to increase the assessment of nicotine and tobacco use in this sample, as well as our provision of evidence-based tobacco treatments to adults with addiction. We saw in a low threshold setting among a population at the highest risk for overdose, not stable in care, that they are engaging with tobacco treatment. So in terms of our future plan directions, we're planning a rigorous scientific evaluation of the Bridge Clinic model in a prospectively designed trial. We're proposing to incentivize follow-up to get better follow-up rates, and we have one pilot study under review and are planning a larger grant right now, but a tough context to do that in. But we're trying to answer the questions of what factors promote MOUD use and retention in treatment, and how and for whom do these new and innovative Bridge Clinic models work. We're also planning to scientifically evaluate the contingency management attendance-based protocol that I shared with you once we implement it and launch it. And then finally, as I mentioned, we have various plans to test novel treatments and delivery methods for integrating tobacco treatment and effective tobacco treatment into addiction treatment settings like the Bridge Clinic at Mass General. So I'll end by just acknowledging our MGH Bridge Clinic leadership team, who very kindly included me in their clinical efforts and their research efforts and gave me access to the data that I shared today. I also want to thank my research mentors for helping me forge these collaborations and so effectively guiding me on this work, as well as our funding sources. And that's all I have for you today. I really appreciate you having me, and I'm interested in our discussion.
Well, thank you, Joanna, for that really stimulating presentation. So this talk is open for questions. I don't yet see any, and none have come in. So I just want to kick off by commending you for integrating the CRA, the community reinforcement approach. And the evidence for that treatment is so strong. I don't know how much evidence there is in the innovative way you're planning on treating it or planning on using it, but I think if you look in the literature, you're likely to find some that at least aligns well with it. But I've always felt a little guilty. We developed that CRA plus vouchers treatment, and people glommed onto the vouchers, which was great.
Yeah.
But in the overall treatment of people with comorbid conditions that came into our clinic, especially clinic for cocaine, almost everybody had other comorbid conditions. The CRA was a really important element to getting good all-around outcomes. If you just focus on cocaine, oh yeah, the vouchers were carrying a lot of the variance in terms of improvements. But if you looked at alcohol use disorders, likelihood of being hospitalized, issues with family relations, getting institutionalized, hospitalized, or put into a prison, CRA was really important. So kudos to you and your colleagues.
Good. Thank you.
And the other thing I have a question about, I've just finished one other thought. Like, there's just so much opportunity for you guys to innovate here. I think that what you're describing on the tobacco is a great example. And I think as you interact with the population, you're likely to see other opportunities. So I just love this model you shared with us today. So we have
Good.
a comment here from Eli Klemper. Thanks for a fantastic presentation. Bridge clinics sound like they provide a wonderful opportunity to have contact with patients with a host of co-occurring problems. Are you aware of any work being done to provide intervention or treatment for non-SUD problems that co-occur in this population that accesses care from the bridge clinics?
Yeah, that's a great question. I am not aware of any work there. But yeah, I definitely agree with you that in addition to studying the larger bridge model, that there's a lot to be done in terms of the psychiatric treatment of the bridge clinic sample. But no, I'm not aware of that. And most of the papers don't even report on prevalence of psychiatric disorders or really even address that at all. So yeah, like I said, historically, I think it's generally been thought that behavioral health and those services are not something that we should prioritize in this population. So I think it's a great research area, Eli.
One rule of thumb we follow, Joanna, on that note, because the comorbidities were so many,
Yes.
that be overwhelming, is if we couldn't make a case for a functional relationship with the likelihood of whatever the problem was, of influencing the likelihood the person would continue using substances that they're in treatment for, or somehow it would worsen, promote relapse, then we would make a referral, but we wouldn't take it on ourselves. Just to have some rule of thumb, because you don't,
Yes.
many different problems are coming at you. We found that helpful. More questions here.
Yes.
Dennis Hand, great work and presentation. Joanna, how are you planning to maintain the fidelity of evidence-based treatments like ACT or DBT? How's the fidelity going to be maintained in a low threshold approach?
Yeah, I think if we were to make this a research study, there are ways that we integrate more seamlessly fidelity monitoring, where we record therapy sessions. We have two raters rate the evidence-based skills used. I'm open to what you think, Dennis, or how you might do that in clinical practice. That's not something I generally see regularly integrated into clinical practice, though one way that we do that is that we have an addiction fellowship where we train our fellows in the evidence-based treatments. Many of them go on to get certified in CRA in the various treatment modalities, and we have a weekly supervision where we talk about the evidence-based principles they're using. But I'm not aware clinically of how people do formal fidelity checks in the way that we do in treatment research. So yeah, if you have ideas, Dennis, and ideas that cost no money, feel free to share those.
Yeah, a follow-up question from Eli regarding tobacco use. Are you aware of the extent to which people who smoke who are receiving treatment at bridge clinics are motivated to quit tobacco in the near future? That might be a helpful guide in developing interventions.
Yeah, that's a great point. I don't know of any studies, nor is there data that I'm aware that we're collecting that assesses motivation. A lot of the studies that we're writing have a more harm reduction lens, where our outcome is reductions in cigarette use. So yeah, but it would be, if we could find that data, that would be an interesting study in itself, Eli, of quantifying level of motivation in that sample. Yeah.
Other questions, comments for Joanna? Don't be shy, please. Oh yeah, here's one from Owen Murray. Wonderful to learn about your work in developing the evidence base for low barrier MOUD, which is clearly vital to increasing access to life-saving medications. In the context of Vermont's robust hub and spoke MOUD care system, where many patients receive holistic integrated care, I believe some patients nonetheless choose to discontinue these comprehensive services and initiate MOUD with low barrier telehealth providers. Have you experienced this in your bridge clinics?
So our bridge clinics do the hallmark of what our bridge clinics provide is low barrier provision of MOUD, including through telehealth. So I think the answer to the question then is yes, since that what you're describing people do in your model, I think is the nature of our model, if I'm interpreting that question correctly. Or is the question here, now that I'm reading it, do people who are offered more comprehensive treatment just want the MOUD essentially and not like therapy or other services maybe? Yeah, I think that we do have many patients who are just there for MOUD and decline therapy. Like I don't provide therapy to everyone in our model, certainly. So yeah, I think your experience, Owen, is probably similar to some of the patients we see as well.
Other questions, comments? I thought Owen's comment is very good, but it just underscores in my mind the need for a bridge clinic. That is a need for a variety of different services. So there are some people, as you were describing in one of your hypothetical examples, somebody who can only take a 5-minute session and then has to get up and process whatever. We can't have a one size fits all with these, really dangerous forms of drug use these days, and truly is often life or death. So we have a question here, or a comment here, a question from Dinah Sattenspiel. You can see them, your questions, so go ahead. I won't read them for you, Joanna.
Yes.
Yeah, sometimes people can't see them.
No, I appreciate it. That was a luxury. Thank you. Any studies on positive outcomes with achieving opioid, alcohol, or stimulant cessation when also electing for cessation of nicotine simultaneously? Yeah, that's interesting. I was actually looking at this. I know, Steve, for your CM review, I was doing a didactic on this, and I think you guys have published on CM for polysubstance use.
A general rule of CM for polysubstance use, it can be effective, but you typically get a lower
magnitude.
Yeah, go after too much, you kind of start weakening the treatment overall. But I don't get the sense that you're overreaching as much as you're going to be trying to move people along in their efforts to improve their lives. And so like with tobacco, my guess is you're going to be among the first to be encouraging in a professional way that some of these folks consider doing something about their smoking or what other form they're using.
Also related to this question, I know Stacy and others have also published work showing that when someone is abstinent from nicotine, they've seen spontaneous reductions in opioid use. So yeah, relevant to the question that was just asked by Dina, I think there are studies showing that when you achieve nicotine cessation, it's often helpful for other people's substance use cessation, even though historically a misconception was that if you quit nicotine, you'll destabilize and start using other substances. That's been since debunked, I think, pretty thoroughly.
Yeah, agreed.
Okay, there's another question that says, could you touch more on the issue of burnout among those providing substance use treatment at bridge clinics? How can we or the general scientific community address the issues of burnout or high caseloads? That's a great question. I do have some ideas for that. I think one thing that our clinical director is working on doing in our MGH Bridge Clinic is having various check-ins, or I don't want to call them support groups, but more spaces for support for people ranging from our front desk staff at these clinics to our providers to share challenging cases and get feedback. What I implied in my talk is another method of that. If you have one more clinical priority you're trying to hit, like tobacco use, that it would benefit from being shared among the providers. So it's not just one role group who's in charge of tobacco treatment or whatnot to lessen burnout. And then also, I think for many of the roles, a huge thing that our clinic works on is proper compensation for these roles. So making sure that we're recruiting people and paying enough for those that are in these roles. And often another piece about your question about caseload is a lot of people have, an admin day where they're not doing 40 hours of cases, but there's time built into their salary to do administrative work or have non-clinical hours, essentially. But burnout is a huge issue, and I don't know that I know of any huge solution to it other than people in leadership roles being attentive to it and doing the best they can, and that their resources can provide to address it.
I'll ask you a question.
Oh yeah, please.
About services you may or may not be thinking to offer. Sarah Heil's work on contraception, because
Yes.
the risk for unplanned pregnancies and subsequent
Yes.
complications for women, for example, who have OUD.
Yes.
Again, where do you draw the line? What are you going to ask
Yes.
about? What are you going to try and
Yes.
do something about clinically?
Yes, that's a great point. So I should have presented, there is a schema that Sarah Wakeman has that shows all of our addiction clinics at Mass General and their purpose. So what I presented on today is our adult bridge clinic, but there's a sister clinic called the Hope Clinic, which is specifically for women, families, people who are somewhere on the spectrum of pre-postpartum. So there is a specific clinic that addresses everything that you're saying. And also in our clinic, it is standard practice to do things like STD tests or provide contraception at no cost. So I think that is pretty well addressed in our system.
Wow, that's great if it is. That's another example of your innovativeness, because as I look back on the years of us doing the cocaine treatment, that was one that was not on our minds, and it's unfortunate that it wasn't, because there is good evidence that an unplanned pregnancy often locks the women into poverty. We know is a tremendous risk factor for other substance or for substance use disorders. So there's a rationale for doing what you're doing, a strong one. Yeah.
It's such a good point, and this is largely the work of Sarah Wakeman and her clinical innovations and advocacy for funding at Mass General. But I've read Melinda Gates's book, which is all about, her entire thesis is about how being able to control as a woman when you have a pregnancy and planning that is like the single most important factor of exactly what you're saying, staying out of poverty, professional advancement, among many, many other factors. I don't see any other questions in the chat. Any other questions?
Well, it's really been a wonderful session, and I'm so impressed and look forward to following the work that you're initiating. It's innovative, it's important, and I think it's characteristic of just the wonderful work that you and your colleagues at MGH are doing in the area of substance abuse generally, and never losing sight of the importance of including tobacco. So, yeah.
Thank you. Thank you so much for having me here. I appreciate it.
Excellent. So thanks to our audience for being with us. And don't forget, we'll be advertising the April lecture, and hope you'll join us again.
Thank you all.
Wrap up. Thanks. Bye-bye.
Take care.